keep joking how, we've traveled internationally to see beauty, and it's right here. This is literally the most beautiful place I've ever seen.
About 7-8 years ago, Tim and I started thinking about how we wanted to teach our students about patient safety, about quality care improvements.
So it's a real opportunity for us to share a lot of our successes of how we're able to save lives and improve the quality of care in this unbelievable community that's incredibly picturesque. It's one of the greatest places you could imagine, where you get a lot of really smart, passionate people together to talk about important issues like patient safety.
Coming to Telluride, it's like a think tank. And that's how I sort of view it. It's a sharing of ideas. It does become a family in some ways, because I can tell you, we've had some heated discussions. I mean, there have been people that have left in tears because they're upset, but that's how you make change.
The level of interaction and communication between all of the participants, ranging from the medical student to the physicians. Everyone's talking on the first name basis. Everyone's treating each other with respect.
You've got people who are just starting out as medical students and never been involved in patient safety before, to people like Lucian Leap, who, founded the field basically. To have that kind of cross-generational collaboration is really amazing.
We are inhibited by factors that don't allow us to be open and honest with ourselves when things don't go right. In fact, a lot of articles talk about people are afraid to reach out to a fellow caregiver and have that conversation, and because there aren't enough care for the caregiver programs, there aren't enough communication, training, and support.
It's sad that this was at the time considered to be a revolutionary concept. But when I came in 2001, I said to the university, why do you need a court system to tell you when you've acted badly? We know when we've acted badly.
Sometimes it's months until you get an autopsy back. And in the meantime, what were we doing? We weren't communicating to patients and families. That did not exist.
We need to provide solutions that are practical and that students can be a part of now. Right. So not only do they get the story, not only are they aware of the culture and the barriers, but they actually start to become a part of practical solutions.
People in their own facility come up with a good idea. We need to share that. And if we leave it bottled up, then we're only going to affect a few people. But if we can spread the message not only across the United States but around the world, we're going to make a huge difference to the quality of care as well as the safety of care.
I was amazed when I came to medical school how behind the medical profession was in the patient safety, risk management, operational risk management.
What I tend to come back at is there are actually two processes of change going on in healthcare right now, and they're in parallel. One is the clinical delivery system being reformed and modified, improved quality, improved safety. And what else is going on is a reform of the educational strategies, not just with physicians, but within nursing and other non-physician professionals. And unfortunately, so far, it's kind of these parallel tracks. So bringing students in at this type of a level allows us to begin building those bridges between these two parallel tracks.
Well, I guess when I told people I was going to Telluride, some of them said, "What are you bothering about this quality and safety business for?"
We realized that there was a big issue that was out there that we needed to address, and that was communication. And in particular, how do we train the next generation to understand the importance of open, honest, and professional communication?
We found that there's not really a value placed on effective communication, in that when we interview medical students, it's not really valued that much. When we decide who's going to be chair of certain departments, communication and leadership isn't always valued.
In the last few years, there's been more and more awareness of the power, the negative power, of disruptive and disrespectful behavior. We had a huge effort to try to figure out how to do this. How do we shift the emphasis away from blaming and individual performance, and if you just tried harder, you wouldn't make mistakes, to implementing this concept that the problem in medical education isn't that students don't learn error signs at all. It's that they are being exposed to role models that are teaching them disruptive and disrespectful behavior.
This humiliation is not only hierarchical humiliation. There are attendings who are humiliate other attendings. This is not something that is just attending to resident or resident to interns. It happens across the top of the structure as well, fairly frequently.
I don't want to sound cynical at my early point in my training career, but we have a lot of very enthusiastic first year or second year medical students who look at this stuff and go, how could this happen? And then you have people even just a few years farther along like me who see very easily how it could happen and how it does.
Leaders in patient safety have been saying, what do we have to do to create a culture of safety? That this is not just a matter of processes and having new systems, that we really have to change the culture.
The problem can't be just individual people not caring about doing a good job or not caring about the patients. That may happen occasionally, but there's something that we need to work on in the culture.
I think it's something that most people don't become aware of until they're further on in their careers, and at that point, you're as ingrained in the culture of medicine as it is today.
Where will the young doctors learn about quality and safety? And they're not going to learn it from many of their peers, because a lot of the older people in the medical profession haven't learned these concepts at all. They're not going to be good role models.
We said, one of the things we got to do is, bring together a group of people who have great educational backgrounds, who understand how to develop a curriculum, and put them together with patient safety experts, leaders at the society and national education level, as well as bring in patients and patient family members, and have this roundtable where we could really have think tank ideas and put together curricula around how you teach students and residents the art of patient safety.
At the heart of the matter, what is the priority? And it becomes where you have to think it's no longer about me and it's no longer about you, it's about the patient.
And I think finally bringing in the patient side of it has been a missing piece and is so important, because until you've been on that side of the equation, you don't understand how the patients and families look at this and how that affects us.
Patient safety should be a core concept, not a specialty. We just need to remember that everyone needs to be involved.
It's nothing like anything I've ever experienced before, to get such intelligent, educated, passionate people together in one room discussing such an important, life-changing concept.
The people here are wonderful. Everybody here is in the choir, and people sing different voices, have different voices in this choir, but we're all here to improve patient safety and quality.
As Dave has often talked about, some of the greatest ideas come when we're hiking up to a waterfall where you really begin to share a lot of this sort of work. So it's an amazing experience. It's a total immersion of your soul, your emotions, your intellect, with all of these other people that are around here inspiring you.
Sometimes I worry about the future of quality and safety in health, but then when I see the future leaders, and these are the future leaders, I'm feeling somewhat reassured.